Okay, so thanks everyone for joining our webinar this evening. I'm going to hand you over to the Leo Cancer Care team.
Thanks, Fiona. So thank you for joining us today, wherever you are in the world, whatever time of the day it is for you. We know you've taken time away from your work and your families to join us, and we appreciate it. My name is Mike Bauer. I'm the handsome debonair guy 30 years ago in the picture in the lower left there. I'm the Chief Commercial Officer at Leo Cancer Care. But if you met me away from work and asked what I did for a living, I would tell you that I'm a radiation therapist by training first. And that's because I'm very proud to be a radiation therapist. And over 20 years away from the clinical setting, I still keep my licensure current. So today I could technically treat, but if you see me coming down the hallway in your department in a lab coat, we're probably going to run behind today. I'm just letting you know. And so I am joined by three of my favorite humans on the planet. And my Leo colleagues, and together we represent many different decades of radiotherapy experience, three separate countries and two continents. And so we're very excited to see you all here today. I pass to you, Dean.
Thanks very much, Mike, for the introduction. I'm Dean Willems, European Sales Director, and also a radiation therapist by trade. I worked clinically for 5 years, and I've remained in the radiotherapy sales arena for the last 35 years. And radiotherapy maintains my passion at work, and it's still a fantastic field to remain in, and what we're doing it with technology moving forward is just phenomenal. And I'll hand over to Jemma.
Thank you, Dean. So I'm also a HCPC registered therapeutic radiographer. I joined Leo Cancer Care 2 years ago now. Previously to that, I worked in the NHS as a clinical therapeutic radiographer for almost 10 years. During that time, I treated patients, and I was also a pre-treatment lead radiographer. And now I get to pull all that clinical knowledge into advancing this amazing and innovative technology here together with these amazing people as part of the Leo team. So I'll pass you over to Kate.
Hi everyone, I'm Kate. I am the Clinical Engagement Manager at Leo Cancer Care, but prior to that, my radiotherapy journey started 15 years ago when I was studying in Cardiff, and then my journey carried on in the NHS, and I only joined Leo a year ago, and that's when I sort of stepped over into this role. And when I was clinical, I was an on-treatment review radiographer, so I spent a lot of time one-to-one with patients, helping them holistically through their entire sort of cancer journey. And that's where I sort of joined Leo, is to share my expertise and my skills of working with patients and my passion for making radiotherapy, the experience of radiotherapy, a really positive one for patients, and especially looking at it from an upright perspective now. So I'm going to hand you back over to Mike for the introduction to it all.
Well, we hope you're hearing a buzz about upright radiotherapy. We're contributing to that, we hope, as well. But we did not create upright radiotherapy. It has been around since the advent of modern radiotherapy. The picture at the top of this slide shows a patient being treated in 1938 in Turkey somewhere. Rock just recently passed this to us. And then some of you may recognize the photo just below it from your textbooks. I know I did, and maybe I'm dating myself again, but this is the dawn of modern radiotherapy being treated upright at Stanford University in one of the world's first LINACs. And this particular is fitting that Stanford would be a pioneer in this, because they are one of the first people to invest in our technology going forward. One thing that can be said about this early cohort of patients is that they arrived in our cancer centers significantly further down their cancer journey, meaning they were sicker than they are in today's cancer centers. And the treatment times were almost always significantly longer. So we feel that probably contributed to cementing supine as the paradigm for treatment, that the patients were sicker and that the treatment times were significantly longer.
Thank you, Mike. So now on to a section presented by myself and Dean about the Leo technology. So as you can see here, and I feel it's really appropriate to introduce the patient rotation system first. This is like the jewel in the crown, if you like. And so this is Eve, and you may notice there's a theme with our products, that they are all named after trailblazing women in science. So what you're looking at here is, and what the concept really, to begin with, is to highlight that it is the patient that rotates and the beam is fixed. And when we train about this system, we think about it in two halves. So everything on the floor level provides your 6 degrees of freedom. So there's a short video in the top right hand corner for this, which shows complete 360 degrees rotation in both directions. We have longitudinal, lateral and vertical motion, and the floor also pitches and rolls 3 degrees. So that's how we're enabled to get to the isocenter. And then moving upwards on the device, you can see here one of my colleagues set up in the system. So working upwards, you can see that the shin and the heel rest, and really this is the secret sauce, if you like, to the product. It was designed with patients in mind, and it was designed with patients that perhaps have reduced mobility. This system enables us to safely immobilize patients that perhaps have reduced mobility, because it enables them to relax all their muscles into it safely to hold them in position. And then moving up to the seat pan, where you'll see that this isn't a normal seat angle. It's not at 90 degrees in this photo. We are able to perch patients. And what this enables us to do is to deliver treatment to lower pelvic regions without any of the beam traveling through the upper thighs. So that's what we use for anything sort of below the carina level. And we can also seat the patient in a fully seated position for things like head and neck. You can also see here that the backrest is at an angle. So you can pitch it forwards and backwards, plus or minus 15 degrees in 5-degree increments. And another fact here on this one, which was very exciting to me with manual handling, is that you'll notice the backrest is half the thickness of a standard supine couch top. It makes it extremely light to pull in and out of the system. And again, thinking about repetitive things that us as radiographers do in our day-to-day practice, I feel like this was a great advantage. You can also see here that we have standardly available immobilization devices, and we use those for patient comfort and reproducibility and stability of the patient. So I touched on immobilization. So on the next slide, we have an example of a vac bag. And again, these are all familiar devices to us as radiographers. You can see there the underside of the vac bag really nicely molds to the seat pan itself. There's no question where it fits on the system. It is as solid as a rock. And moving on to the next clip, this is an abdominal compression belt. Now, we haven't actually tested this in research as an abdominal compression belt, but we have tested it on many patients who give feedback that this helps them to feel stable in the upright position. One gentleman even described it as a warm hug. Moving on to the head and neck immobilization region, you can see here that we've split it into a shoulder and a head mask. There's two reasons for this. The theory that it produces more stability, there's no gaping around the neck region, and also it could potentially be paired, as you sort of see in this image, with surface guidance. And then finally, because we're in the luxury of being in a more upright position, what we're able to now experiment with, and what we're designing, is an adjustable almost arm tray, where we still need to stabilize the patient's upper body, and really now the role becomes in still getting the arms up out of the way. So something like this can comfortably be used with patients that are having abdomen and pelvis treated. And we've actually had feedback from patients that they would love a position to put their iPad in. So I'll hand you over to Dean to introduce Ruby.
Thank you, Jemma. To add to our clinical product portfolio, we're developing the Ruby Linac, our photon therapy solution, named after Ruby Payne Scott, a pioneer in physics. Ruby is not yet clinically available, however. Ruby recently won the IF Design Award label this year in 2024. Ruby's designed to improve clinical effectiveness of radiotherapy using upright positioning Eve, what we just saw, coupled with our static Linac, removing the need for rotating gantries and using a slow patient rotation, all with a state-of-the-art control system, combining imaging, positioning, and treatment delivery in an intuitive workflow. It allows patients to remain upright and feeling in control and communicating eye to eye, like we just saw, with radiographers and clinical staff. With all the attributes of the Eve, Ruby has an isocenter accuracy of less than a millimeter, a continuous 360-degree slip ring rotation in the floor, which is variable up to 1 RPM, a 6 MV FFF beam, a dose rate of 1200 centigrade per minute, an SAD of 100 centimeters, and MLC leaves of 120 30 by 30 centimeter field size. And all these leaves have a full over travel and interdigitization of each leaf. And the leaf speed, interestingly, is 10 centimeters per second, which is twice as fast as the fastest available today, which delivers fantastic beam modulation. It comes with CBCT imaging with energies running from 40 through 120 kV, and it's a fixed horizontal positioning. It also has a built-in primary beam stopper, which enhances the overall shielding requirements. We also have an optional SGRT system with 5 cameras that allow you what we just saw earlier with the Eve system to position your patients. So the benefits this can bring is that static gantry and horizontal cone beam imaging lends itself to super rock solid treatment and imaging beam geometry with no compromises with what we see traditionally with rotational gantry sag. So physicists are going to be delighted with this optimal beam stability and reliability. The single beam orientation with primary beam stopper means less shielding all around, saving on building costs and the overall footprint. So for greenfield sites and for existing bunkers, you can really take advantage of the fact that there's only a single beam pointed in one direction. The upright orientation means ease of patient setup, optimized posture, and enhanced throughput with more compliant patients with this stable positioning and the potential to reduce strain injuries on radiographers. Patients' clinical benefits for head and neck, breast, lung, and pelvis can be realized, and we will explain these in greater detail as we move through the slides. Ruby lends itself well to being mobilized. Next slide, please. The Ruby lends itself well to being mobilized due to its small footprint and reduced shielding requirements, and could really be used in outlying underserved communities in combination with hypofractionation. So watch this space. We'd like to also introduce you to Marie, which combines our upright patient positioner Eve with our upright fan beam dual energy wide bore CT, all with the state-of-the-art control system, also combining imaging, positioning, and adaptive imaging at the isocenter. Like Ruby, Marie allows patients to remain upright and feeling in control, communicating face-to-face with radiographers and clinical staff. Using a fixed beam with patient rotation removes the need for large rotating gantries, be they 6 tons or 600 tons, enabling rapid installation in existing and new bunkers. Marie can be combined with virtually any fixed beam output, including, for example, protons, carbon ions, very high energy electrons, VHEE, boron neutron capture therapy, BNCT, and, with Ruby, photons. Marie can acquire both diagnostic quality pretreatment images for treatment planning capturing the upright anatomical volumes of interest, and treatment imaging for setup and adaptive therapy indications. Patients can be scanned and treated at the isocenter. Marie offers a large 85 centimeter bore with a 62 centimeter field of view, imaging energies of 80 and 140 kV with a 1 millimeter slice thickness, and gantry tilt of plus minus 15 degrees to follow the Eve patient positioner, and a large travel range of 175 centimeters. So the benefits, like Ruby, upright orientation for the ease of patient setup, optimized posture, stable positioning, and reduction in strain injuries of radiographers. Patient benefits we're going to describe as we move along. Marie also allows you to scale down the size of proton and heavy ion delivery systems, thus reducing capital costs in construction, maintenance, and opening up the technology to be adopted by more institutions and bringing the technology to more and more patients who really need these types of treatment.
Thank you, Dean. So now we would like to play a system workflow video for you. So the first thing to note here is that the therapist is taking the system to the load and imaging position. This is all pre-saved because the only things that do not move under automation are the backrest and obviously the insertion of personalized immobilization. As you can see here, the patient is able to set themselves up or begin that journey of setup themselves. And what you may have picked up on by now is that during this whole process, the therapist has maintained eye-to-eye contact with the patient and they are able to talk on that level throughout the whole process. So as we move forward to imaging, the ring comes down over the patient and it acquires the images as the system tilts upwards. Now you can see that the system rotates really smoothly between the treatment angles. It rotates at 1 RPM. So once the treatment is finished, again, it's an automated return to the position. And you can see here for this gentleman that once a mobilization is released, he's able to actually get himself out of the system unaided.
Well, now I think we're going to take a more clinical look. You've had a look at the products and a look at the workflow, and we assume that there'll be questions about that, and we're happy to answer later. But macro look at who benefits from upright radiotherapy. Our studies suggest that fully 3/4 of oncology patients could benefit from upright radiotherapy. We know they would all benefit from the psychology and the emotional advantage of being treated upright, but there are actual anatomical and physiological benefits to each of these, and we're going to talk about them in a little more detail. You'll notice that when we make statements that we are usually citing a study from the facilities shown here. At the conclusion of our presentation, each of these studies will be made available to you if you'd like to do some more research.
So we're going to start things off with looking at the research into the benefits of treating lung cancer with in an upright orientation. So this particular piece of research was carried out at MD Anderson in 2013. And the two images that you've got on screen is the patient on the right-hand side. So patient A was in an upright position when they were scanned, and patient B on the left-hand side was in a supine position. And the lungs themselves have been outlined in yellow. And as you can see, when comparing those two images, is that patient A has a much greater lung volume there. So what the research found was that on average, there was a 20% increased lung volume when in an upright position. And for some patients, that went up to 50%. So there were much greater lung volume when in an upright position. And if we're thinking about patients that are struggling with breathlessness, So those are the patients that have either got lung disease, COPD, asthmatic patients, particularly anxious patients. All of these patients will benefit from having that increased lung volume to really get a nice deep breath in to make their treatment more comfortable for them. And say for patients that do have that anxiety, we often say to patients, take a nice deep breath in when we're trying to help them relax. And it's that deep breath in that allows them to be better oxygenated, to let their heart rate settle that little bit more, to stop them getting into that more panicked state when they are feeling more anxious. And for breath hold patients, so patients that are having left-sided breast treatment, we often will treat them in a breath hold position. So we'll get them to take a deep breath in and hold that breath. And patients often really struggle with that process. And they get quite anxious that they're not breathing in deep enough, and they're worried about cardiac and lung toxicity. So by being in an upright position, that breath hold process is going to be a lot easier for them and get better results as well by having that increased lung volume. This research as well also looked at breathing motion, and it found that there was a 5 millimeter reduction in breathing motion when in an upright position. And what that means when we're treating a lung tumor itself is that you've got less movement of the lung tumor. So when we've got our beam on, we can be more confident that tumor itself isn't going to be moving up out of the target volume when the patient is breathing during treatment. So less breathing motion will mean less tumor motion as well. So we're now moving on to the benefits of treating liver in an upright position. It's not something that we routinely see in a radiotherapy department, but it does raise a number of questions for us. So this piece of research was carried out at the Paul Scherrer Institute. And what it found is that the liver itself continues to move. So when you're moving from that upright position, then into a supine position, as we would with standard radiotherapy, it's the actual movement from upright to lying down can cause the organ itself to continue to move. And if you think from a clinical perspective, when we set a patient up, we get them lying down, we then perform our scan, there's a little bit of a pause while we're assessing our scan, then we beam on. And if you think we've got that time period where there's the potential then that the organ itself and thus the tumor itself is continuing to move. So what this research found was that over 35 minutes, the liver itself will continue to move up to 20 millimeters. So you've got a 2 centimeter movement of the organ itself from the point of potentially where you've scanned. So by the time that you beam off, there's the potential that things have moved to that extent. And it starts to question, could that be happening to other organs that we're treating as well? So this video is just going to explain that and show it to you in a visual way.
When we lay down, the liver drifts for up to 35 minutes, moving in some cases up to 20 millimeters, meaning without careful monitoring, the tumor could move out of the treatment field, causing healthy tissue to be irradiated.
So it's showing the tumor itself has now moved out of that beam that was being delivered at the time. So we're now going to move on to the prostate. So the clinical benefits of treating the prostate in an upright position with Dean.
In a recent study carried out by Nick Schroeder at Leo Cancer Care, 15 volunteers were scanned in an upright MR system, allowing for both imaging in the supine and upright position. And we looked at patients, we looked at these subjects, these volunteers, with both a full and an empty bladder to assess the anatomical changes in the orientations and study the potential for the upright prostate treatment. What was significant is that the bladder full versus empty in the upright position didn't significantly impact the position of the prostate, as it seems that the contents of the actual abdomen are actually forcing the prostate into a fixed position versus the movement that we see of the prostate with a full or empty bladder in the supine position. So this is a very interesting finding that we're seeing here. And also, when you are upright, the anterior posterior length of the bladder width is larger and more pancake-like. The seminal vesicles seem to be pushed down by the bladder, and the distance between the sacrum and the anterior bladder wall is smaller. The top of the penile bulb is further away from the apex of the prostate, and the position and shape of the prostate really isn't impacted by bladder filling. So this brings up some potential benefits to the patients. The ease of setup and comfort during treatment without the need for having a full bladder for treatment. The reduction in dose to the penile bulb, better coverage of the seminal vesicles with dose, and the potential to reduce the need for rectal spacers could all be really great benefits for delivering upright radiotherapy for prostate. And over to Mike.
Perhaps I have drawn the easiest of the anatomical sites to speak on. When we go on site to give presentations, one of the first questions and the first anatomical sites that get brought up is head and neck treatments. I think this is a fairly obvious use of upright radiotherapy. We all know that these patients come into our clinic. They're some of the sicker patients that we see. The immobilization is significant. The treatment is oftentimes disorienting for them. But what we all know to be true is that it's easier to swallow. Your secretions drain more naturally in an upright position than you do in the supine position. And if you've ever been to the dentist, and I hope you have, you can attest to this, that it is far more difficult to swallow in a supine position than upright. In addition, we have getting feedback anecdotally from physicians who examine their patients, head and neck patients, in an upright position, and then the subsequent CT anatomy looks different. And so we are hearing from physicians that are excited to see agreement between the CT findings and the physical examination findings. And so head and neck, we see that as a significant utilization of upright patients in the patient load for upright treatment machines.
Thanks, Mike. So now I just wanted to talk to you about breast. So here at Leo Cancer Care, we're very fortunate to have some amazing research partnerships. There was a paper that has been published in Frontiers in Oncology, together with Leo and Centre Léon Barrard and Sheffield Hallam University. We studied the upright positioning for gantry-free breast radiotherapy, a feasibility study using a robotic chair and specialized radiation bras. And what we looked at was we studied overall body position, the arm position, the possibility of beam access, and the reproducibility and comfort from the participants. And this was all done with healthy volunteers. So what you can see here is the inframammary skin fold measurements using comparing the different radiation bras against being topless. And then on the right hand side, you can see here the arms up positioning and the use of the different radiation bras and the effects that has on the inframammary skin folds. And then moving on, you can also see on the second slide here that there is a patient comfort questionnaire that went with this. And so we tested out the arms along the body, the arms behind, and the arms up to reflect the more traditional supine methodology. And we also tested out the patient rotation system, Eve, in a completely seated position, a sort of perch position, and then a almost fully perched or standing position. And what you can see here is that generally across all aspects, the participants felt really comfortable in all of these positions, which is great to see.
So we're going to be looking into now sort of the psychological benefits of being in an upright position. And for me, when I found out about upright radiotherapy, there were a number of patients that instantly sprang to mind, and I'm sure that you're thinking the same. And for me, the first patient group that I thought might benefit were palliative patients, because we've all had those patients that have come down from the ward in their bed, nicely propped up, comfortable, talking away as normal. And then we have to do that horrible thing as radiographers where we have to ease the backrest down on the bed until they're lying completely flat, so we can pat slide them across to the treatment bed. And it's as we bring the inclination down on the backrest, you can hear the discomfort in the noises that they make and the cries that you sometimes get from patients. And it's really difficult for us and for the patient to get into that lying down completely flat position. And also cognitively impaired patients as well. I had a gentleman at the end of my clinical career where he came in to us, again, nicely propped up in a chair. He had quite advanced dementia, so he wasn't fully aware of what was happening, but he was very comfortable in his chair. And again, we had to spend quite a long time, sort of an hour or more, trying to get him down, lying completely flat and completely still for 20 minutes. And as his wife said, he doesn't even lie down flat for when he goes to bed. He stays up in his chair, and he's very comfortable that way. And that brings into question that in an upright position, it's a more natural position for a lot of people. We spend most of our day upright, and it's only when we go to bed at the end of the day that we do lie down completely flat. Our body is used to maintaining an upright position, getting ourselves in and out of a chair when we sit down to watch TV or to eat dinner. We're always in that position, and it's more natural for us. And also bringing it through to this next point here as well is, I often used to get feedback from ladies that are having their breasts treated that they could hear there was someone in the treatment room, but they couldn't see them. And that for them, they were in quite a vulnerable position where they were feeling quite exposed. And then their field of view is completely gone, because without patients lying supine, all they can see is the ceiling above them. And we'll often actively say to them, as soon as they look anywhere else, it's like, oh, stay nice and still, keep still. So our patients are being deprived in some ways of one of their main senses, which is sight, because all they're allowed to sort of really look at during the treatment process is the ceiling above them. And we know from a lot of healthcare research how important nonverbal communication is. And when our patients are lying down, staring up at the ceiling, they're lost to that. So communication is 7% verbal, 38% vocal, but 55% is visual. And so they've lost that really important communication because of the position they're traditionally treated in, which is lying down. And eye-to-eye contact with our patient is so important, because it allows us to convey to our patients empathy, reassurance. We often help patients relax by practicing mirroring behavior. And also it allows us to pick up on those subtle hints from our patients. When we can see their facial expressions better, if we're face to face with them, we can pick up on those little cues from them that they're in discomfort or they're feeling really anxious. So we're missing out on that, as well as radiographers being able to read off our patients better. And also there was a bit of research that got feedback from patients that were having cancer treatment that were deaf. And they found that particular patient group were the least likely to ask for clarification if they didn't understand something. But it's so important for them to be able to lip read, to see sign language. So it raises the question of informed consent as well. If our patients can't fully communicate with us, are they really giving the informed consent? And also they have understanding of what's happening to them, which then helps to increase compliance, understanding, and reduce anxiety for them as well. So then we move on to feelings of empowerment. Yoga talks about this power pose, so shoulders back, open chest. And if you look at it on a biological level, that from a biological perspective, as humans, we need to be able to use all of our senses in order to assess whether we feel we are in danger. So if we're depriving our patients of one of their main senses, as I said, which is sight, then that's when anxiety can start to pick up. And they're not feeling like they are completely aware of what's going on around them. That's when that vulnerability creeps in and those feelings of anxiety. So if we're putting our patients back in that upright position where they can assess for themselves that I'm in a safe environment, then that feeling of anxiety can settle, because they've been able to see for themselves that, okay, I'm in a familiar environment now, I can see that I'm safe, and they can reduce that feelings of anxiety and feelings of helplessness as well. Because having radiotherapy is a really vulnerable time for patients. So if we can really make them feel like they're central to their treatment and have that connection with us as their therapists, then we can reassure them that they are safe and that they don't have to worry.
And if I could just pile on, Kate, if you don't mind, and this is one of the final slides, y'all, if you're still hanging in there. I wanted to just point out that I have been to 23 or 24 consecutive Astros, and I have had the privilege of working for many of the fine companies in this industry. And in all that time, I have never seen a prospective customer lay down on a supine couch at a trade show. Now, some of these, there are very practical reasons. They're wearing suits and their finest business attire, but there's something more at play here. And if you come by the Leo booth, and perhaps some of you already have, you will notice a queue of people. And these people include physicians, physicists, therapists, CEOs, politicians, celebrities. We have had the run the gamut of people have come and taken a seat during a trade show and experienced the upright paradigm. You will not find that in the supine tables. They usually will pay a model to do it. And I don't think that it's because it's extremely uncomfortable. I'm not claiming that. I'm also not claiming that there's not a place for supine treatments and radiotherapy. I'm just saying that that folks find this position to be powerless and not fitting for the positions they hold in their professional lives. And if that's true for us, then it's also true for our cancer patients. And I'll just leave that out there. But the slide up here is showing from the Centre Léon Bérard Center, and it is led by a radiation therapist, this paper. And it is taking oncology patients that are being treated supine and repositioning them in the relevant position upright, and then asking them a series of questions. And so these are actual oncology patients being treated in one position, but positioned in both positions. And what was notable is that the patients found it much more comfortable to breathe. They found it more stable, and they found it easier to get in and out of the system. Incidentally, that was true for radiation therapists as well. Pass to you, Jemma.
Thanks, Mike. Yeah, it's a really interesting point here to wrap things up on and reflect on, really, as my time, and I'm sure we can all relate to this. Being a therapeutic radiographer or radiation therapist is very physically demanding on our own bodies. We're constantly changing in mobilization on and off the treatment couches. Our tasks are very repetitive, perhaps up to 30 to 40 times a day. And we're also manual handling patients. So really what's happening is that we're twisting and bending at the same time. And the Society of Radiographers conducted a study back in 2012, which reported that 80% of all radiation therapists that they surveyed will report a musculoskeletal injury, which might require some absence from work. And really that the injuries were focused around the neck, the wrists, and the lower back region. And really, there's a feature of the system that is really going to help with this, and it's the seat height. Unlike with supine, you locate your headrest, the patient moves up to the headrest. We actually need to take the system and adjust it to the patient's height. But what this enables us to do is, with patients that are perhaps a little less mobile, or after being sat for a while, they lose that momentum, we can actually drive the system up, which enables us to get the patients up to a more standing position and stabilize them before they start to mobilize out of the system. So again, it's giving almost dignity back to patients, because you're not having to assist them, you're not getting into their personal space, but it's also reducing the demands of manual handling on our bodies. So I would like to just thank you for listening in this evening, or during your clinical day, wherever you're joining us from. Now we would like to invite you, if you have any questions, to place them into the chat, and we will begin to answer them. And again, if you'd like to follow us on social media or any of the other platforms, I will just leave the details here for you for a moment. And then there's just a references slide as well.
If we don't get to your question, somebody will respond in kind, but hopefully we can get to them. during this call.
Hi team, thank you for the great webinar. We are starting to get some questions in. One of them being, how do you put thermoplastic immobilizations for head and neck cancers?
Probably Jemma or Kate question.
Sure. So we have been working with one of our immobilization partnership companies, and we are developing a head and neck backrest. So as I alluded to at the very beginning, the fact that the thermoplastic is half the thickness of a supine couch makes it incredibly easy to take in and out of the system. So therefore, we will be able to then attach or have a separate backrest that goes in and out of the system, and then it will be compliant or attached to thermoplastics in the same way that we do in supine, just with the standard clips around the top.
Great, thank you.
You're
We
welcome.
have another question that's come in. In a hospital setting, a number of patients are bedridden. How will they be treated?
Kate, Jemma, do either one of you want to take that one? I think Kate, you started to allude to it in your setting or in your slide.
Yeah, it really does depend on the reasons for the patient being bedridden, but we're doing a lot of research with occupational therapy and manual handling experts on how we can use the manual handling devices that we currently have and we use in radiotherapy departments all the time. So whether that's a hoist, for wheelchair users, we've got the great benefit of a simple device such as a banana board where patients can just literally push slide themselves across. So you can put their wheelchair right next to the system and then they just slide across. So depending on how much core stability that person has, and as well as the immobilization devices that we have, it's certainly the system is useful for all sorts of patients and their accessibility. So we're trying to make it a system that is accessible for all and use what we know as radiographers, all those different manual handling devices that we already have and we're already well trained for.
And I think it's important to reflect, Kate, as well, that, you know, we're not replacing supine radiotherapy here. We acknowledge that there will be a small cohort of patients that perhaps upright will not be appropriate for. And that really is down to us as professionals, that we constantly assess patients' fitness to treatment on a daily basis. We've had this question many times, particularly from lower limb amputees, actually, and we're working with, as Kate says, different scenarios where we can adapt the system. Again, it's moving the seat height in line with the level of the wheelchair. And if they have that upper body strength, it's about them transferring themselves across, as well as using other immobilization devices that we're all used to seeing today in clinical practice.
We've got another question here. Any special plans for treating pediatric patients without anesthesia or with anesthesia?
You know, I'll take the first stab at that, and then perhaps somebody can jump on and pile on with mine. This is an entire presentation of its own, and so anything I say would just be very topical to answer this question. Yes, there are plans. Yes, there is some resistance to the idea of treating pediatrics in an upright position, but not as much as we were led to believe. Our Chief Scientific Officer, Nick Schroeder, has a published paper about the pediatrics, which you can see at any of the trade shows, and is also we can send to you, that shows a system whereby we can modify our seat to create the devices for patients in an upright, or to deliver the anesthesia in a supine setting, and then tilt them to an upright position for treatment. If you talk to Nick, and he's possibly on this call, he will tell you he's very bullish about the possibility of pediatric upright radiotherapies becoming the mainstay for patients. It is not unheard of for people to receive anesthesia in an upright position. We think obviously of some dental patients, a lot of shoulder surgeries require it. And so this is an obstacle for us, but it is not an insurmountable one. And indeed, the early adopters, the people who've bought in to our technology early, are quickly finding ways to deliver this treatment type. And so, does anybody have anything to add from the panel on that one? And Nick, I don't know if he probably doesn't have the ability to jump in, but we're happy to provide more information to anybody who seeks it.
I think to add
I
to that, Mike, that we're also looking at, reducing the need for the
That's right.
anesthesia through distraction technology. And that combined with the upright position is much easier to actually administer with the patient in the upright orientation versus laying on their back and trying to distract them while they're on their back.
Facts, and that's already work that's well underway and established prior to upright radiotherapy, reducing the need for anesthesia in pediatric patients. Anything to add on that?
We also, if you follow us, you may have seen that we announced a recent partnership with a company called Exploro, and they are working with us. They do lots of audiovisual materials for pediatric patients in different hospital settings. And you may, if there's anyone on here that's attending Estro this year, they are going to be spending some time with us on our booth. So come and have a sneaky peek at what's been going on with us there.
We have another question. On average, how much time does the treatment require?
Anybody, Kate, Jemma, do you want to jump in?
I would say that the feedback that we've had from the Centre Leon Barrard, who have had our system for sort of 2 years, and they're the ones that have been doing research with patients that are already having supine treatment. The feedback from them is that the setup time is so quick now because we don't have the need for to help assist our patients in that sort of getting into that supine position. The actual setup time and the reproducibility is much more than is much quicker than what they're seeing in sort of supine treatment. So to actually get a patient in position ready to go for treatment is a fraction of what we normally have on a day-to-day supine treatment.
And so while Jemma and I are on the trade show floor, we often demonstrate this for people, and we create a backlock bag for them and their devices, and then we store the actual locations of everything except the shin rest. And patients will greet them as if it's day 2, where we already know the position of all of their devices. They come in, they sit on the device that's already created for them, and we have them in a position ready for imaging, oftentimes in less than 30 seconds. And so we all know as radiographers, to use your term, radiation therapists for the US folks, that there's some things that cannot be hurried. Walking Miss Jones back to the radio, she's going to tell you about her grandchildren, and she's going to do it at her pace. And so, the only thing we can do to speed that process is the hand in the small of the back as you're walking down the hallway. But we can change the entering and the exiting from the machine and speed that up considerably, as well as the intraoperative variability of acquiring images and positioning patients for treatment. Anything to add on that, Jemma? No?
No, I think that's a great summary. Thanks, Mike.
How are we doing, Fee? More questions?
I'm just double checking. No, I think that's probably all we've probably got time for. Oh, actually, there's one last one come in that says, for the Marie system, how tall is the clearance?
I can take that one. I mean, in terms of the room requirements, you need a 3-meter ceiling height.
And for the folks in the U.S., this translates into, I think, a little over 11 feet. A little over 11 feet is what we're requiring. So is that correct, Dean? Check my
Sounds right.
Canadian American conversion, England to conversion.
Right, I think that's all we've got time for this evening. Thank you everyone for joining. We are recording this session, so we will try to make this, we'll try and post this so you can rewatch if needed. And thank you to our wonderful speakers. Have a great evening, afternoon, wherever you are. Thank you very
Thank you
much.
so much.
Thank you.
Thank
Thank you,
you.
everybody. Bye-bye.